this presentation. My name is Daniel Holley, and today me and my group are going to be going over the ACL ruptures and the knee joint in general. And my job specifically is to be going over the ACL in general and the bones and muscles of the knee. So getting straight into it, the bones of the knee. So there's three bones in the knee. There's the femur, the tibia, and the patella. So the femur has three parts: the proximal, the shaft, and the distal. I'll be going over the distal part of the femur since that is actually with the knee, while the other two parts are not as so much. So the distal end of the femur is characterized by the presence of the medial and lateral condyles, which articulate with the tibia and patella to form the knee joint. The medial and lateral condyles are rounded areas at the end of the femur. The posterior and inferior surface articulate with the tibia and menisci of the knee, while the anterior surface articulates with the patella. The more prominent lateral condyle helps prevent the natural lateral movement of the patella. A flatter condyle is more likely to result in patellar dislocation. There's also medial and lateral epicondyles, which are bony elevations on the non-articular area of the condyle. There's also intercondylar fossa, which is a deep notch on the posterior surface of the femur between the two condyles. It contains two facets for the attachment of interscapular knee ligaments. The ACL attaches to the medial aspect of the lateral condyle and the PCL to the lateral aspect of the medial condyle. So now getting into the tibia also has a proximal shaft and a distal part of the bone. I'll be going over each of these parts before the tibia. So the proximal tibia is widened by medial and lateral condyles, which aid in weight bearing. The condyles form a flat surface known as the tibial plateau. This structure articulates with the femoral condyles to form the key articulation of the knee joint. The tibia is the main bone of the lower leg, forming what is more commonly known as the shin. It expands at its proximal and distal ends, articulating at the knee and ankle joints respectively. The tibia is the second largest bone in the body, and it is a key weight-bearing structure. So now getting into the middle part of the tibia, or the shaft. The shaft of the tibia is prism-shaped with three borders and three surfaces: the anterior border, the posterior surface, and the lateral border. The anterior border is palpable subcutaneously down the anterior surface of the leg as the shin. The proximal aspect of the anterior border is marked by the tibial tuberosity, the attachment site for the patellar ligament. The posterior surface is marked by a ridge of bone known as the soleal line. This line is the site of origin for the part of the soleus muscle and extends inframedially, eventually blending with the medial border of the tibia. There is usually a nutrient artery proximal to the soleal line. The left intersoleus border. It gives attachment to the intersoleus muscle or membrane that binds with the tibia and fibula together. So now getting into the distal part of the tibia. The distal end of the tibia widens to assist with weight bearing. The medial malleolus is a bony projection continuing inferiorly on the medial aspect of the tibia. It articulates with the tarsal bones to form part of the ankle joint. On the posterior surface of the tibia, there's a groove through which the tendon of the tibialis posterior passes. Laterally is the fibular notch, where the fibula is bound with the tibia, forming the distal tibiofibular joint. Now getting into the final bone, the patella. The patella, also known as the kneecap, is located at the front of the knee joint within the patellofemoral groove of the femur. Its superior aspect is attached to the quadriceps tendon and inferior aspect to the patellar ligament. It is classified as a sesamoid bone type bone due to its position with the quadriceps tendon and is the largest of these type of bones. The patella has a triangular shape with anterior and posterior surfaces. The apex of the patella is situated inferiorly and is connected to the tibial tuberosity by the patellar ligament. The base forms the superior aspect of the bone and provides the attachment area for the quadriceps tendon. The posterior surface of the patella articulates with the femur and is marked by two facets: the medial facet and the lateral facet. And the patella also has two main functions, which is leg extension and protection. So now that we have a little bit of a description of each bone, I'm going to go into the common fractures of the knee, the upper tibia fracture and the patella fracture. So starting with the upper tibia fracture. This fracture or break in the shin bone just below the knee is called a proximal tibia fracture or an upper tibia fracture. Proximal tibia is the upper portion of the bone where it widens to help form the knee joint, as I said earlier. In addition to the broken bone, soft tissues like the skin, muscle, nerves, blood vessels, and ligaments may be injured at the time of the fracture. Both the broken bone and any soft tissue injuries must be treated together. In many cases, surgery is required to restore strength, motion, and stability to the leg and reduce the risk for arthritis. A fracture of the upper tibia can occur from stress or from already compromised bone, but most of these fractures occur from trauma. Young people experience these fractures often as a result of a high energy injury, such as a fall from a considerable height, sports related trauma, or motor vehicle accident. Older people, however, with poor quality bone often require only low energy injuries, such as a fall just from a standing position to create these fractures. The symptoms of an upper tibia fracture include pain that is worse when the weight is placed on the affected leg, knee, and limited bending of the joint, deformity of the knee, or a pale, cool foot, which is a pale appearance or cool feeling from the foot that may suggest that the blood supply is in some way, or numbness around the foot. So now getting into the other fracture that I have here, the patella fracture. So a patellar fracture is a break in the patella or kneecap, the small bones that sits just in front of your knee. Because the patella acts as a shield for your knee joint, it is vulnerable to fracture if you fall directly on your knee. A patellar fracture is a serious injury that can make it difficult or even impossible to straighten your knee or walk. Some simple patellar fractures can be treated by wearing a cast or splint until the bone heals. In most patellar fractures, however, the piece of bone move out of place when the injury occurs. For these more complicated fractures, surgery is needed in order to restore and stabilize the kneecap and allow it to return to function. A break can occur at the top, center, or lower part of the bone. Sometimes fractures occur in more than one area of your kneecap. And the patella can fracture in many ways. Fracture can be a simple, clean two-piece break, or the bone can break into many pieces. So now I'm going to be going over some of these different types of fractures that can happen to the patella, starting with the stable fracture, which this type of fracture is non-displaced. The pieces of the bone may remain in contact with each other or separated by just a millimeter or two. And in a stable fracture, the bones usually stay in place during healing. Now getting down to the second one, the displaced fracture. In a displaced fracture, the broken ends of the bone are separated and do not line up correctly. The normally smooth joint surface may be disrupted, and this type of fracture often requires surgery to put the pieces of the bone back together. And then getting into the comminuted fracture. In this type of fracture, the bone shatters into 3 or more pieces, and depending on the specific pattern of the fracture, a comminuted fracture may be either stable or unstable. And then the final fracture is the open fracture. In an open fracture, the bone breaks in such a way that the bone fragments stick out through the skin, or a wound penetrates down to the bone. An open fracture often involves damage to the surrounding soft tissues and may take a longer time to heal. Open fractures are particularly serious because once the skin is broken, there's a high risk for infection in both the wound and the bone. Immediate treatment is required to prevent this infection. So patellar fractures are most often caused by falling directly onto the knee, receiving a sharp blow to the knee, such as might occur during a head-on vehicle collision if your kneecap is driven into the dashboard of the steering wheel. And the patella can also be fractured indirectly. For example, like a sudden contraction of the quadriceps muscles in the knee can pull apart the patella. So the most common symptoms of a patellar fracture are pain and swelling in front of the knee, of course, but other symptoms may include bruising, the inability to straighten the knee or keep it extended in a straight leg raise, or even the inability to walk. So now that we've gotten through most of the bones, we're going to be getting into the muscles of the knee. So actually, this is a group of muscles called the quadriceps. It's actually, like I said, it's a group of muscles. So I'm going to be going over each one of these muscles and their attachments and actions that they help with the knee. So starting with the rectus femoris, it originates on the anterior inferior iliac spine and a groove superior to the acetabulum. It inserts on the common tendon of the quadriceps, enclosing the patella, and on the tibial tuberosity. And these actions include extension of the leg at the knee joint and flexion of the hip. So now the vastus lateralis, it originates on the greater trochanter and upper lateral surface, the linea aspera, inserts on the patella via the quadriceps tendon and the tibial tuberosity via the patellar ligament. And this action, along with what we're talking about, is the extension of the leg at the knee joint. So the vastus intermedius originates on the upper 2/3 of the anterior and lateral surface of the femur, inserts on the common tendon of the quadriceps, enclosing the patella, and on the tibial tuberosity. And like I said, it extends the leg at the knee joint. So and then getting into the last one, the vastus medialis, it originates on the intertrochanteric line and the medial lip of the linea aspera, and it inserts on the common tendon of the quadriceps, enclosing the patella on the tibial tuberosity. So now I'll be getting into my final slide, besides my cited sources, of course, bones and muscles affected by an ACL tear. So I'll be going just very briefly over what the ACL is, what an ACL tear is, and then I'll be going over why I've labeled all these bones and muscles here and why they are affected by an ACL tear. So The ACL is one of the four main ligaments of the knee joint that connect it to the tibia and femur. It's located deep within the joint behind the patella, above the shin bone and below the thigh bone. The ACL keeps the shin bone in place and prevents it from moving too far forward or away from the knee and thigh bone. So the ACL can be injured in several ways: changing direction rapidly, stopping suddenly, slowing down while running, landing from a jump incorrectly, or even direct contact or collision, such as a football tackle. The symptoms include pain and swelling, loss of full range of motion, tenderness along the joint line, or discomfort while walking. And also quadriceps and hamstring weakness occurs frequently after the ACL injury and reconstruction. So as you can see, every single one of the bones and muscles that I have labeled here today, or even earlier in the slides, they are affected by an ACL tear because, well, it's just that bad. Like, ACL tear is one of the worst things that can happen to not only an athlete, but just anybody in general. As it said before, it connects the tibia and femur. It's right in there with the patella. All the quadricep muscles are inside there. They're going to not be able to move as well. And even your hamstring muscles, which I didn't even go over because they're not really a part of your knee, are also affected by these tears because of just how bad this tear is. So these are my cited sources, and I'm done with my part. Welcome Kasey for the next part of our group.
All right, so my name is Kasey Mann. Like he said, I'm going to be covering the knee kinematics and the range of motion of the knee. More specifically, the kinematics of the knee in walking, running, stair climbing, and also in sitting up and standing down. So first off, I want to start with the range of motion of the knee. Oh, the slide went too fast. Okay, there we go. Range of motion of the knee, we have flexion and extension, and then you have internal and external rotation, but then you also have abduction and adduction, which more specifically called varus and valgus. So here in this picture here, you can see an example of flexion and extension. And then this bottom picture is varus and valgus forces. Most of the time when you see those, it's when people are standing straight up. They'll have knock knees or bent knees or bow-legged knees, or even when they're walking, sometimes their knees do tend to move in more. So it could be a variety of the two. With flexion, like Daniel said, the biceps femoris, the semitendinosus, the semimembranosus, gracilis, sartorius, gastrocnemius, and the plantaris are all involved in the flexion. And then for extension, you have a couple more. They are the vastus medialis, the vastus intermedialis, the vastus lateralis, rectus femoris, and that is it for those. So there's a bunch of muscles in the knee that cause flexion and extension, but those are just some of them. So I'll go ahead and get into the knee kinematics part of this. First off, we're going to start with walking. Walking has two main phases. The first phase is called the stance phase, and it takes about 0 to 65% of the actual step. The other phase is the swing phase, where it takes about the rest of the time. So 65 to 100 would be the swing phase, which comes out to about 35%. The stance phase takes up 3 different phases in itself. You have the initial, the middle, and the terminal. So for initial, it is from the heel strike to flat foot. So let's say you start with your left foot. So when your heel hits to a flat foot, and then middle is from flat foot to the opposite heel strike, and then terminal is opposite heel strike to toe off. During this phase, the knee mainly acts as a shock dampening mechanism to accept the body weight, because there's so much weight going through the knee at all times while you're walking. So you have to have something there to just accept the shock. And patients with ACL tears have decreased knee and joint flexion and extension during the stance phase specifically, so it makes it a lot harder for them to walk. The next phase is the swing phase of walking, so you have initial and terminal for it as well. The initial is from toe off to knee maximum flexion, and then terminal is from knee maximum flexion to heel strike. During this phase, the knee assists with flexion and extension for toe clearance, as well as foot placement and taking over the load of the next step. So you have to have something to be able to bear the weight while your other foot's in the air for the split second that it is. So therefore, the knee is going to do all of that for you in that time. During walking, the knee biomechanics are mainly affected by your speed. So as your speed increases, the range of motion, max extension moment, and max absorption power will also increase. And this is the same as running as well. So depending on how fast you're running or how fast you're walking, you're going to have a lot more range of motion and power. So the range of motion for walking is around 53 degrees to 75 degrees. So it's not too much of a degree difference that you need for walking, but you still need quite a bit to be able to walk. And then the range of power during the knee in walking is 1.035 to 3.214 watts per kilogram. So not much power is being produced at all during walking. Next up, we have running, and there are 4 main phases of running. The first phase is stance. The second phase is first float. Then you have the swing phase, and finally the second float. So for the first phase, the stance phase, it takes about 40% of running. It's the heel strike to the toe off. So again, let's start with your left leg. You're going to strike your heel and then toe off really quickly while you're running, and then that is that whole stance. The next part is the first float. So basically you are kind of floating at this point, but not really. You're still kind of touching the ground. Your toe is off, and it's kind of in the middle of that and the opposite heel strike. Then you have the opposite heel strike to opposite toe off for the swing phase, which is about 30%. So it's a bigger phase as well. And then you have the second float, which is opposite toe off to heel strike, and it's about 15%. So both of the floats, you're barely floating. It doesn't take much time at all. But the stance phase and the swing phase are a lot longer. Main knee function during running is, again, similar to walking. It is a shock dampening mechanism to assist in flexion and extension to make sure you can get that range of motion in your knee. The range of motion is around 60 to 115 degrees, so it is actually a lot more than it is for running. For walking. And then the range of power is 8.724 to 21.972. So it's a lot larger power output in your knee when you're running than it is when you're walking. Next up, we are going to cover stair climbing. So stair climbing has 2 main phases other than the ascent and descent. It is the stance phase and the swing phase. And again, stance takes up the majority of this. It is a 62% motion for the stance phase, and then the swing is only about a 38% motion in stair climbing. So it's a little bit smaller than, actually a little bit larger than walking. So 3 main phases as well in the stance phase: initial, middle, and terminal. Initial is when the foot contacts to the opposite toe off. The middle is opposite toe off to opposite foot contact, and the terminal is opposite foot contact to toe off. And then the swing is just bringing your other leg around to finish that step. So it's not too big of a deal with the swing phase. So knee biomechanics in this phase are mainly affected by the rate of leg length and the stair height. So if you have a small leg and a really high stair, it's going to be hard for you to climb up that. But if you have a large leg and a small stair, it's going to be a lot easier. So it just depends on how long your legs are and stuff like that. Range of motion for stair ascent is around 78 to 94 degrees, while stair descent is 76 to 90 degrees. And the range of power for stair ascent is 1.309 to 3.48. So not a lot of power there. And range of power for descent is 2.114 to 6.054. So there's a lot more power that you need for descent because you're trying to keep your body from falling down and going with gravity. During any walking, running, climbing, anything like that, the knee joints demonstrates a spring-like behavior in common motions, such as, like I said, the walking, running, and all that. Many researchers believe that due to non-uniform shape of the knee, the articular surface and the structure of the femur and the tibia actually cause the knee to roll instead of hinge. Most people believe it is a perfect hinge, but it actually isn't. It's more of a rolling motion around a fixed joint where the tibia rolls against the femur, and that is coupled with the motion of rolling and sliding followed by pure sliding. So in doing that, you're not actually hinging like the knee actually looks like it's more of a rolling motion. And then here are my references. And then Taylor is going to come in and cover some other stuff.
Next slide. Hi, so my name is Taylor Dorsey, and I am going to be discussing the etiology of ACL ruptures. So first thing I'm going to be talking about is what actually happens when you have an ACL rupture. So the anterior cruciate ligaments, or also known as ACLs, rupture occur most commonly in young and active individuals. This specific injury most often occurs during sports and exercises and happens also suddenly and without any warning. It could be a result of any cutting or pivoting on a person's foot when one lands on one leg very differently. It could happen when the knee is bent slightly inward, outward, or slightly just like not abnormally, or it becomes hyperextended. That can also cause a rupture or a tear as well. Like I mentioned before, sports in general are the most common cause of ACL tears. Like I said before, in sports like volleyball or basketball, that involves a lot of running, jumping, or any quick movements. Okay, so right here, I just have just a basic diagram of the ligaments that are in a knee. So as you see up front, here's the ACL. You can see the medial tibial plateau. You can see the synovial membrane, the superficial fibers of the tibial collateral ligament, the MCL, deep fibers. This figure shows, like I said, all the ligaments that provide all the static stability that we need for the knee. What's used for our quadricep and hamstrings that help it contract to produce dynamic stability, and the menisci form a cushion between the bones, and that's also attached to the tibia, and it deepens the tibial fossa and enhances stability. So overall, the anterior cruciate ligament is one of the key ligaments that helps stabilize the knee joint. That also includes the posterior cruciate ligament, or the PCL, and the medial collateral ligament, which is the MCL. The ACL connects the femur and the tibia, and it becomes ruptured when any rotational trauma to the knee and is associated with damage to extrascapular knee rotation stabilizing structures, such as the interlateral ligament. So right here, this is just a figure that shows the interlateral ligament. It's labeled ALL. So I don't know if you can see it from the mouse right here. I don't know if it's over it, but that's just one diagram to show. So now I'm going to talk a little more in depth about that specific ligament. The anterior ligament is a lateral aspect of the human knee and anterior to the fibular collateral ligament. It is believed that when you tear your ACL, studies have shown, like in many other patients, 90% of patients with ACL tears also tear this ligament as well, but it's not viewed as a separate structure or component. But now that it is known as a separate structure, after looking more in depth into these patients who suffer from these tears, it is known regarding for knee stability and helps control tibial internal rotation, which is essential for locking and unlocking your knee. I'm just going to talk a little bit more in depth about the injury one in itself. The injury to the ACL overall removes the major stabilizing structure to the tibial translation. The initial trauma can lead to meniscal and cartilage damage, predisposing the knee to early degenerative changes. The knee with an isolated ACL rupture may have recurrent episodes of instability that can lead to similar degenerative courses. So that's why most people who suffer from these tears go through many balances and many exercises so they can be able to regain that strength and regain that stability to go back, become better and stronger when they return. One cannot accurately predict which patients will tolerate ACL deficiency and which patients will not. Current long-term studies support a progressive worsening condition in the ACL and meniscal deficient knees. Physical therapy together with lifestyle modifications may be necessary, and those unwilling to make these types of changes or those with associated injuries may benefit from ACL reconstruction. All right, so these are my references, and here is Kaitlyn going to close us out.
All right. Hello. Hi. So my name is Kaitlyn Springer, as Taylor mentioned, and now that she has explained the general principles related to ACL tears, I will be discussing specific factors contributing to the higher incidence of ACL ruptures that occur among the female athlete population in particular. So ACLs in general are a common sports injury, but this is especially and disproportionately the case among female athletes. In addition, females are more likely to sprain their ankles or develop stress fractures, among other sports injuries. And ACL tears are 3 to 10 times more likely to occur in females versus males. And the incidence of ACL tears also varies by sport type. The highest rate of ACL injury among both genders, but even more so in females, occurs in contact type and fixed object high impact rotational landing, or HIRL for short, sports. So examples of contact sports would be soccer, basketball, and field hockey, and HIRL sports include gymnastics and obstacle course centered competitions. When a female tears her ACL, she may experience immediate and long-term risks and health consequences depending on the severity of the rupture. So that could be, the severity could be related to the width and depth of the tear and whether or not other joint structures like the menisci or cartilage are also torn during the injury. So as Taylor touched on, in the short term, ACL tears often necessitate surgery to reconstruct the ligament and stabilize the knee, which often involves high medical bills and physical rehabilitation. So this may impact the athlete or her family's financial status and the athlete's ability to play in her sport, since recovery time is typically about 1 year for this injury. And then over time, in a longer term, ACL tears can predispose women to develop other health problems such as osteoarthritis, which can be compounded even further because women are at risk for osteoporosis. So that those two compounding together can be a problem in older age, and a degrading knee joint that needs a total replacement can also be another complication later in life. So now that I have established the difference in prevalence by gender for ACL ruptures, I will discuss some of the anatomical and physical distinctions between males and females that researchers and medical professionals predict may be causing this disparity with females having such high incidence. So as I mentioned in my previous presentation about hip injuries, females have proportionally wider and shorter pelvises than males as an adaptation for childbearing. Females' wider pelvises that changes the angle of alignment of the femur, tibia, and the kneecap and their associated structures, and that is thought to shift the line of force pull in knee mechanics. Furthermore, some believe that females' hormone balance predisposes them to connective tissue injuries, especially in the ACL. So first of all, greater estrogen is associated with an increase in joint laxity. Estrogen levels fluctuate throughout a woman's menstrual cycle, with the highest during the luteal phase prior to menstruation, and this high laxity can lead to compromised stability of the joints, especially in the knee. Additionally, females typically have much less testosterone, than males circulating in their bodies, because increased testosterone increases the ability to build muscle mass. Females with low testosterone tend to have less muscle mass in their bodies and in their legs. Thus, they generally have less force capacity in the quads and hamstrings, which are muscles that provide dynamic stability to the knee. So they have less of that stability due to lower muscle mass. And then last point on here is that due to female and males' differing limb and pelvis proportions, there's a difference between their typical Q angles, which is short for the quadriceps angle. Higher Q angles can lead to genu valgum, which Kasey mentioned earlier, and that's also known as knock knees. So due to its frequent topic, I will discuss the Q angle further on the next two slides. So here we have an image of a measurement of a Q angle, and the quadriceps angle is defined in Friedman's article as the angle between the line of application of the quadriceps force and the direction of the patellar tendon force. Practically, it can be measured using techniques like the one pictured in the image on the right. So the instrument that is typically used is called a universal goniometer, which contains markings to determine the degrees of the angles of the body in various positions. So this goniometer will be aligned proximately at the anterior superior iliac spine of the hip, and then the wheel will line up around the patella, and then the distal arm of the goniometer will land around the tubercle of the anterior side of the tibia. There are some discrepancies within the literature and guidelines about what the optimal position of the body is to measure the quadriceps angle from. So whether that be standing, like in this example in the picture, or if it would be better to sit, and then whether or not to have the quads contracted or relaxed. Also, although there's a great deal of recent research about the Q angle and its role in female ACL tears, I must note that controversy does exist about the validity of this measurement to numerically describe the quadriceps direction of force. Also, its relationship with patellar maltracking, which is a key component of ACL tears and other injuries, is disputed. So although it may be a helpful thing, some scientists do not believe it is as accurate. But I'll discuss it a little further from what I found in my research. So next we'll look at the average differences between males and females Q angles, which I have mentioned, and those are depicted in the image on the left side of the screen. So males typically have an 8 to 10 degree Q angle, whereas females usually are 15 to 20 degrees. On the illustration, note that the female's Q angle, which is the one on the right that's shown at the 16 degree line, is more gradually sloped inward than males. Experts have explored the influence of various anatomical differences on the effect it has on the Q angle, and they believe differences may be due to females' proportionally wider pelvis or their shorter femurs, or some combination of factors. And as previously mentioned, a large Q angle may cause the quadriceps muscles to pull on the knee joint with excessive lateral force, so outward, and injure the anterior cruciate ligament beneath the patella. When a female tears her ACL, there are a number of movements and dynamics typically implicated in the injury. First, movements involving a pivot or jump are usually involved in an ACL tear. If the leg moves into a position of exaggerated valgus knee with the hip in adduction and internal rotation, along with a pronated foot and ankle, the athlete will be at risk to tear her ACL. Furthermore, sudden changes in speed, especially rapid deceleration, place abrupt forces on the knee joint that can cause an acute rupture. As discussed on previous slides, some believe that females' larger Q angles influences their quadriceps direction of pull. Last, females' increased laxity in the connective tissues decreases the stability of the joint when they're moving. So due to the high prevalence of knee injuries among female athletes, many have studied effective interventions for reducing this risk. One key approach is to use strength training to increase muscular strength to promote dynamic stability of the knee joint. Specifically, the hamstrings are often targeted to obtain more balance strength compared with the quadriceps. Also, using drills to increase coordination throughout the range of motion of sports movements and landing can establish healthier motion patterns to avoid the valgus knee and prone ankle. Neuromuscular training, which is abbreviated NMT, is a program that is showing promise in the prevention of ACL ruptures in females. Studies have demonstrated that the risk of ACL injuries reduces by about 50% after an intervention using this model. NMT incorporates strength training, plyometrics, balance exercises, and stretching. The diagram on the right is a best practices checklist for NMT programs for female athletes developed by Petushek and his team. As shown, some of the exercises considered to be the most effective for this purpose include Nordic hamstrings, heel raises, lunges, and landing stabilization practice like jump and holds. Also, this diagram emphasizes that interventions with younger athletes are more effective because they establish good body mechanics and strength earlier on. So in conclusion, the purpose of this presentation was to discuss the knee and ACL tears among athletes. Daniel established the normal and healthy anatomy of the knee and mentioned a couple fractures. Kasey discussed the kinematics involved in everyday movements utilized in many sports. Taylor explained the etiology of ACL tears in general, and I narrowed further by discussing specific issues that female athletes face with their ACLs. And key takeaway points of this presentation were that the knee joint is weight-bearing and important in many movements. Range of motion in the knee permits mobility while maintaining relative stability unless we move into extreme motions. And ACL ruptures are prevalent, costly, and traumatic injuries, especially in sports, and female athletes are more vulnerable to ACL injuries. Shown here are my references utilized both for the informational content and images in this section. Thank you very much for watching.